Thank you for joining us today, and I hope everyone is having a great day and a great meeting. My name is Dr. Bhavana Pathuri, and I will serve as your moderator for this afternoon's symposium titled ADCs First to Cervical Cancer and Here to Stay, Understanding Provider and Patient Perspectives. The GOG Foundation would like to thank our commercial supporters, Seagen and Genmab, for their generous support to make this possible for you all today. So let's get started. We'll begin with speaker introductions, and we have an incredible panel here of friends and colleagues, and I really like to hear them introduce themselves, so we're going to start with Dr. Campos.
Hi, my name is Sue Campos. I'm a medical oncologist at Dana-Farber.
Hi, good afternoon. Leslie Randall. I'm a G1 oncologist at VCU Health in Richmond, Virginia.
Kathleen Lutz. I'm one of the nurse practitioners at the NYU Perlmutter Cancer Center.
Hi, I'm Andrea Kinlock, and I am the patient advocate today.
Yeah, so we are really so lucky to have this distinguished group up here. And I'm particularly grateful for Andrea, who's traveled here to be with us and to provide the powerful patient voice and perspective. Here are our disclosures. So this is our agenda for today. We've done the welcome and introduction. We're going to do a quick introduction to ADCs, understanding mechanism of action, and a case presentation by Dr. Campos. Then we will have Dr. Randall do a TV 301 phase 3 an adverse event review. And then we'll move to Kathleen Lutz, who will talk about education, adherence, and symptom management. And finally, we will have Andrea speak about the patient perspective. After that, we'll have a panel discussion and Q&A. We're going to try to make it interactive with the panel, and please feel free if you have questions. Are there microphones? Yeah, use the microphones, and I'd love the more engagement, the more enriching this session is going to be. So I would really love active participation. So today, our learning objectives for this symposium will be to review the current landscape for the treatment of recurrent cervical cancer based on pivotal clinical trial data and insights from 2023, to understand the role of ADCs in cervical cancer and how to educate patients on this novel treatment option, to review and incorporate updated data in the treatment decision-making through case-based learning, and finally, to understand the patient perspective with respect to receiving treatments in recurrent cervical cancer. So with that, I would like to invite my dear friend, Dr. Susana Campos, up.
Hi, good afternoon, good morning, good afternoon. It's way afternoon in Boston. So we're going to spend a little time talking about ADCs and how they've changed the path of many different disciplines in gynecological cancers, including this of cervical cancer. So when you think about it, ADCs are leading a new era of targeted therapy. When you think about ADCs, we think of them in the present. We know them. We try to pronounce them, okay? But the truth be told is they have a past, and they have a past that dates almost 100 years ago. In 1910, Paul Ehrlich coined this term, the magic bullet. And over the last 100 years, it's been through lots of trials and tribulations, we have now over 100 ADCs and many in clinical study. In essence, in 2000, the first ADC was approved for acute myelogenous leukemia. It was called gemtuzumab, and this was taken off the market voluntarily so several years later because of toxicity. It was reinstated in 2017. In 2013, trastuzumab DM1 was approved for breast cancer. In 2019, trastuzumab DXd was approved for breast cancer. And in 2021, tisotumab vedotin was approved for 21. And there's many ADCs, but I can't pronounce them, and those are the only ones that I can, in essence, pronounce, okay? So when you think about ADCs, you think to yourself, well, you're delivering chemotherapy, so what difference does it make? It does, because you have a targeted approach. We all know that with conventional chemotherapy, the therapeutic window is actually quite small. And the hope is that with this ADC, with a targeted approach, that you widen that therapeutic window. Now, when you think about antibody-drug conjugates, you think about what are the components. It's like the anatomy of an ADC, not to be confused with the anatomy of a fall, an excellent Oscar award-winning show. However, the anatomy of an ADC actually has components, and it has the components that include the target antigen, the antibody, the linker, and the cytotoxic drug. I like to think of this, and they've often coined these, and you read articles about ADCs, and they talk about it, this biological missile. Well, if you have a missile, it has to launch, but it has to land in the most appropriate way. And in addition, every part of that missile has to act in concert, in union, to actually make that happen. So what are the components of an ADC? When we think about the target antigen is actually the navigator for the ADC. And what do you expect in an antigen? You expect that it's going to be expressed wholeheartedly on the cancer cells and nowhere else. You expect that it's going to be extracellular, and you expect that it's not going to be secretable. In terms of the antibody, and we'll talk a little bit more about this, is for a guidance system for the cytotoxic drugs. The linker, so very, very important, okay? This is the bridge between antibody and drugs to control the release of the drugs into the cells. In many ways, this is a key factor for the stability of the ADC, and ultimately, this actually directs therapeutic care. The cytotoxic drug, in this particular case, we're going to be talking about DNA tubulin inhibitors. We're also going to be talking about DNA-damaging drugs such as topoisomerase I. So this particular slide is a very basic slide, but I like this slide because it tells a story. Once again, each component and their interactions have a crucial role in determining both the efficacy as well as the toxicity of an ADC. So this little cartoon, the antibody actually is critical for specific binding. What do you expect in an antibody? It has to be tumor selective. It has to be efficient in the internalization to a target cell. It has to minimize non-specific bindings. It has to be non-immunogenic. These are often of the IgG1 subtype, and these are very common in the serum. They're often associated with effector functions like ADCC. What about the linker? Once again, the linker is by far one of the most important aspects of this ADC. It's a key factor for the stability of the ADC, and as I mentioned before, it ultimately directs the therapeutic index. There's cleavable as well as non-cleavable linkers. The cleavable linkers take advantage of an environment difference between that of the systemic circulation and the environment of the actual cancer. They're cleaved by chemicals and by enzymes. The non-cleavable linkers, they're basically inert to chemical or that of enzymatic degradation. However, there's some literature that suggests they actually are stable in the plasma, and that actually may improve the therapeutic index. So exceptionally important. The drug. And we call it drug, but as the years will go by, you'll realize that it's not simply cytotoxic drugs, but it could be immunomodulators. But in this case, we're going to talk about the drug, tubulin inhibitors, and topoisomerase inhibitors. The drug has to have potent efficacy, and it has to have an available linker binding site. Often we don't talk about the attachment site. The linker has to attach to the antibody, and it does so through typically either a cysteine or a lysine residue. This is actually quite important because it actually controls the drug-to-antibody ratio. It actually controls the drug distribution. You want a homogeneous ADC. You don't want one ADC to have one drug and the other ones to actually have three. So again, the components of an ADC, although we give it every day, is actually rather complex. There's some key terminology that we always throw around, and what does it actually mean? We talked a little bit about drug-to-antibody ratio, which is just the average number of drugs conjugated to the antibodies. And this is actually quite important because you would normally think the more the better, but not necessarily so. You want to have enough drug-to-antibody so that you don't minimize potency, but if you have too many drugs to an antibody, you may, in some cases, affect the pharmacokinetics of the actual antibody. What is this term bystander effect? We hear that often tossed around in different ADCs. This is an escape of the released toxin from the targeted cells. It allows the toxins to actually affect neighboring cells and cause subsequent killing. So we're going to be talking a little bit more about that. Now, we often talk about the mechanism of action of these ADCs, and this is a lovely slide that is so pretty that I like to show all the time. Basically, what happens? The antibody binds to the target antigen at the surface of the cancer cell. The ADC antigen complex is internalized and then trafficked through an endolysosomal component. The payload is released in this lysosomal component. The payload enters the cytoplasm, and then the payload acts on either microtubules or on DNA, resulting in cell death. So we talked about the nuts and bolts of an ADC. What are the ADCs in cervical cancer? We're going to talk a little bit about tisotumab vedotin. This is an FDA-approved drug for cervical cancer. The biomarker, the target antigen, is tissue factor. It basically is a fully human monoclonal antibody. It has a cleavable linker. The payload is MMAE, and it has a drug-to-antibody ratio of about 4.1. Another ADC is trastuzumab deruxtecan. This is actually FDA approved for breast, gastric, and non-small cell lung cancer that is HER2 overexpressed. Once again, it's a humanized anti-HER2 IgG1 antibody. It has a cleavable linker. In this case, the payload is a topoisomerase 1 inhibitor, and it has a high drug-to-antibody ratio. This is on the NCCN guidelines for HER2 positive cervical cancer. So let's start with tisotumab and talk about its mechanism of action. We talked about the fact that the antigen is tissue factor, that the payload is MMAE, but it has a multimodality mechanism of action: direct cytotoxicity, bystander killing, which we talked about earlier, immunogenic cell death, ADCC, and antibody-dependent cellular phagocytosis. Now, the target. We often don't speak about this, tissue factor. I will not show you the coagulation system because I think that is cruel, okay? However, what is tissue factor, if we remember that back from medical school? Well, tissue factor basically generates thrombin and generates fibrin, and it activates platelets. So the thought is that these activated platelets and fibrin inhibit the function of natural killer cells and attract monocytes and macrophages. This helps establish a niche for where the cancer actually can take off. Additionally, it can promote cancer growth and survival also by activating certain pathways, such as the PI3 kinase pathway. The tissue factor is highly expressed in cervical cancer, and this high expression of tissue factor may enhance the invasion and the metastases of cervical cancer cells. Once again, the payload is MMAE, and I say this specifically because there are different tubulin inhibitors. This one inhibits the polymerization of tubulin. So what's the clinical data? Well, the clinical data now dates back several years ago, and the first study was the INOVA 204. And this is a phase 2 study of about 100 and 102 patients. The key eligibility criteria was metastatic cervical cancer that had progressed during or after doublet chemotherapy. The primary endpoint was overall response rate by IRC. Secondary endpoints was overall response rate by investigators, duration of response, progression-free survival, and overall survival. Tisotumab was given at the conventional dose of 2 milligrams per kilogram every 3 weeks, and patients continued on therapy until they had progressive disease or prohibitive toxicity. It was a very stringent follow-up. The tumors responses were assessed using either a CT or an MRI at baseline and every 6 weeks for the first 30 weeks and then every 12 weeks thereafter. This led to the FDA approval of tisotumab for metastatic cervical cancer in 2021. And this is the reason why. Efficacy. The overall response rate was 24%. There were 7 complete responses, 17 partial responses. The disease control rate was 72%. The median progression-free survival was 4.2 months, and the median overall survival was 12.1. If you take a look at the waterfall plot, it is in essence quite impressive, with basically having target lesions being reduced 79% of the time. In terms of safety, safety was also well tolerated. In terms of grade 3 toxicity, I'm going to hear a little bit more about this. There was about 28% grade 3 toxicities. There were pre-specified AEs, and this included ocular toxicity, which you can see from the slide was about 2% grade 3. They were mostly grade 1 and grade 2. And they take the form of keratitis or conjunctivitis. In terms of bleeding, which was mostly epistaxis, was about 34% grade 1 and about 2% grade 3. In terms of neuropathy, there was about a 7% grade 3 toxicity. Now, after 204 was 205, and if tisotumab works well, what about combinations? And in this particular study, in recurrent cervical cancer patients, there was a dose escalation and a dose expansion phase. The dose escalation combined tisotumab with Bev, Pembro, or carboplatin. In the dose expansion phase, arm D and arm E, tisotumab was combined with carboplatin and pembrolizumab. In arm F, these were patients that had been exposed to therapy. This is the second or third line, and it was a combination of tisotumab plus pembrolizumab. The dose expansion, the primary endpoint was overall response rate. And as you can see, it was quite impressive. It is true that these are only small cohorts, but if you take a look at the first line tisotumab plus carbo, there was a response rate of approximately 55% with a duration of response of 8.6 months. First line tisotumab plus pembro, overall response rate of 40.6 months. The duration of response was not reached. And in second line, third line, looking at tisotumab plus pembro, 34 patients, the overall response rate was 35.3%. So quite impressive combination therapy. Now, that is tisotumab. What about the other biomarker, the other ADC? In this case, it's trastuzumab DXd, and we talked about the biomarker being HER2/neu and the payload being topoisomerase I inhibitor. Again, it's a humanized IgG antibody with a high antibody-to-drug ratio of approximately 8. Where is the data that supports this particular ADC in cervical cancer? And this really emanated from the Destiny Pan-Tumor02 trial. And as you can recall, this particular trial looked at different disciplines. We will hone in, of course, on cervical cancer. The eligibility criteria was advanced solid tumors, second-line therapy, HER2/neu expression, either 2+ or 3+. Patients could have had prior HER2/neu therapy, and they had to have a good performance status. Trastuzumab DXd was given at 5.4 milligrams per kilogram every 3 weeks. There were 40 patients per cohort. Looking at this particular slide, the overall response rate by HER2/neu status in cervical cancer, looking specifically at IHC 3+, there were 8 patients in this cohort, was 75%. In the IHC 2+, where there were 20 patients, it was 40%. All these patients were HER2/neu positive by local determination, but there was also some central testing in this particular study. When you looked at PFS for HER2/neu cervical cancer and looked specifically at the IHC 3+, the median progression-free survival had not been reached. If you looked at those at the IHC 2+, the median progression-free survival was 4.8 months, and in total, 7.0 months. The most common side effects, and we'll talk a little bit more about this in subsequent lectures, was anemia, actually was fatigue as well as neutropenia and anemia. There was a particular type of toxicity that is extremely important to highlight, and that is interstitial lung disease and pneumonitis. There were deaths associated with this toxicity. Again, we'll talk a little bit more about this. So we've talked about ADCs in the present. We talked about them in the future. The question really is, how will ADCs advance in the future? And this can be a lecture in and of itself. One can talk about the diversification of antigens. We can talk about technology in terms of linkers. We can talk about technologies in terms of conjugation profiles. This could go on and on. But basically, we also have to identify, as we do with just conventional chemotherapy, the mechanisms of ADC resistance. This could be the result of antigen binding, internalization, trafficking, ADC degradation, and in the payload, you could have alterations in target. So we've come a long way, but there's a long way yet to actually go. So, in total, and I think I'm staying on time, the antibody-drug conjugates are monoclonal antibodies attached to biologically active agents through chemical linkers. The hope is that they increase the therapeutic window when compared to that of conventional chemotherapy. Tisotumab vedotin is FDA approved for metastatic cervical cancer. Trastuzumab deruxtecan has activity in HER2/neu positive cervical cancer. So I leave you with some thoughts. Thank you.
That was really great, Dr. Campos, for really nice overview. I guess I want to just see what who in the audience has actually utilized TV. It's now been approved 2.5 years. Just hands up high so I can see. Okay, looks like there are definitely some users. Great. And how about trastuzumab deruxtecan for cervical cancer? Hands up high. So it looks like a fewer. But that has also been a more recent NCCN listing. And for those who have not utilized tisotumab vedotin, based on this data, does it make you feel more likely to use it, or do you plan on using it? Hands? If you do think you'll use it, if you have a patient. Yeah, go ahead.
Do you need phase 3 evidence to feel comfortable using it? Raise a hand.
Okay. It's interesting. Okay. So I think let's move on. You want to do your case? Yeah.
So this is actually my patient. She is a 36-year-old lovely young woman from China. Actually, she's a baker by profession. She bakes us all great things, who actually presented while in China with advanced cervical cancer. Her symptoms upon presentation were pelvic pain and vaginal bleeding. Imaging studies done there revealed a 3.1 by 1.5 centimeter mass, and this had an ill-defined border with the bladder wall. There were lymph nodes adjacent to the iliac vessels, the largest one measuring about 1.8 by 1.3 centimeters in size. According to the records, she underwent a cystoscopy, which showed a space-occupying lesion in the bladder. A biopsy was performed, which revealed a squamous cell carcinoma. It was poorly differentiated, non-keratinizing, PD-L1 positive, HER2 negative 0. At that point in time, she had a PET scan, which once again confirmed avid disease involving the lowest segment of the uterus, the bladder, multiple pelvic lymph nodes, abdominal and pelvic metastases. So while at home, she underwent therapy with carboplatin and Taxol. Subsequently, she underwent radiation therapy to the cervical lesion and the pelvic lymph nodes. A repeat pelvic MRI done post-therapy revealed that she actually had significantly regressed, the tissue had actually regressed, but there was still disease there. Actually, they continued to see some multiple heterogeneous masses in the peritoneum, the left upper abdomen that were concerning from malignant tumors. At that point in time, while in China, she underwent therapy once again with carboplatin, Taxol, paclitaxel, and pembrolizumab. And according to the records, she had about 6 cycles. Regrettably, she progressed, and at that point in time, she made her way to the Dana-Farber Cancer Institute, and a PET scan was done. And this is just a MIB showing the actual extent of the disease. And, she had presented to us with significant pain, especially in her left scapular and lower pelvic pain. The PET scan unfortunately showed multifocal areas of FDG avid metastases. This involved extensively like the bilateral hilar and right internal mammary nodes, soft tissue implants in the abdomen and the pelvis, and multiple osseous metastases. There was FDG activity along the left rectal wall. They thought it was serosal disease. There were FDG avid subcutaneous nodules in the anterior left abdomen and also along the cervix and the vaginal cuff. The patient was seen by pain and palliative care. She was started on pain medication, and she underwent palliative radiation therapy to the left scapula because that indeed was the most significant source of pain. The question is, in the absence of a clinical trial, which treatment would you consider next for the next patient? Tisotumab vedotin, cemiplimab, trastuzumab, DXd, nivolumab plus ipi, or chemotherapy, or other. We don't have a little thing, so we have to raise hands, okay? How many people would pick tisotumab? Okay. How about cemiplimab? How about trastuzumab DXd? How about nivo plus ipi? Loosely based on 358, okay. Chemotherapy? And if so, which chemotherapy? And other. All right.
Okay. So just going back, I noticed that you used carboplatin and paclitaxel as your initial therapy, and probably this was a patient that you saw
Yes.
much earlier. Is that what you would use today?
So this is actually what they, this patient came to us having been treated, in China. And so, we would have used either cisplatin, Taxol. We wouldn't have used Bev because she had bladder invasion. We would use cisplatin, paclitaxel, and pembrolizumab very early on. So,
Right.
yeah.
Based on the 826 regimen?
Based on the 826 regimen, yes. But this is exactly how it played itself out.
Great. All right. I think now we'll invite Dr. Randall up.
Thank you. Good afternoon. So, exciting data, right? And I think, in the U.S., we're very privileged because that TV204 data led to an accelerated approval that happened in September, I think, of 22?
21.
Is it 21, right? It's
I know,
been
it's
that
2.5
long.
years.
That's unbelievable. It's been that long. I thought it was 21, but I thought, no, that was too long ago. Okay, I guess all those years were just a fog for many of us. But, you know, we're lucky to have that accelerated approval mechanism. And I think many of you met my patient who was here yesterday, and she stood before you yesterday because of the availability of that medication on an accelerated approval. Every accelerated approval needs a confirmatory trial to garner its final approval, and TV301 was a confirmatory trial for TV205. And it's also important because this is how the rest of the world gets access to tisotumab for their patients. And before we move on, you know, there's some data out there to show that a lot of patients don't get treatment beyond that Keynote 826 GOG 240 space. So that patient that you had and that you treated at the Dana-Farber, I mean, about 50% of our cervical cancer patients don't even get second-line therapy in the United States. And I think the reasons for that are probably very complicated. And I'd love to hear from our patient advocate on how she feels about that. But I mean, for me, if a patient has a good performance status and they want to keep fighting, that's their choice to go on further therapy, not really sort of, you know, my choice. It's my job to know what those options are. So this trial is important again because it was the confirmatory study for TV204. And this is the phase 3 evidence that will establish the final approval of TV. And I'm glad you put this here because I can't even see that. Okay. This was presented at the ESMO, and again, at this meeting, this again is a phase 3 study that included second and third line recurrent cervical cancer patients. They did have the squamous, adenosquamous, and adenocarcinoma histologies. These patients were randomized to receive the tisotumab vedotin at the standard dose and schedule that was tested in 204 versus standard chemotherapy. And here were just like a whole slew of options that are NCCN listed, and many of us can read these options and know that these aren't the best options for our patients. Many of these treatments have a lot of side effects, and so their efficacy, toxicity sort of ratio, risk-benefit ratio may not be where many of us would prefer for that to be, especially in the metastatic recurrence setting. The outcomes of the study, the primary endpoint was overall survival, and progression-free survival, response rate, and safety were the key secondary endpoints. Here are the demographics of the patients that were enrolled and their disease characteristics. They were very balanced between the two arms, and of importance is the prior anti-PD-L1 therapy. This is the first, second, third line study that really looks at a relatively large population that has been checkpoint exposed. So in this study, it was a little under 30% for both arms. So I think that's quite interesting and something to remember when we look at efficacy. So here's the anti-tumor activity. This is not the primary endpoint. I want to stress that. I just put this first because this session is focused on, you know, our patients, and these are the endpoints that the patients want to know about. I know this is what my patients want to know. It's like, is this going to shrink my tumor? So 17.8 was a response rate seen. That's in opposition to the 24% that we saw in the phase 2. But if you remember, there was a confidence interval around that 24%, that was 16 to 33. So we're seeing the 17.8 fall into that same confidence interval. And then the response rate of chemotherapy was much less than that at 5%. And then you have 2.4% complete responses. You have several partial responses and a lot of stable disease. So pretty high disease control rate here, 76% versus 58%. With chemotherapy, and the median durations of response fairly similar, but when you look at progression-free survival, it was extended in the tisotumab vedotin group over the physician's choice chemotherapy. And we don't have the granular details on, you know, the different chemotherapies in the physician's choice arm. We just analyzed that as a group. and tisotumab outperformed that. And for overall survival, which is the primary endpoint, which is the endpoint that everyone should use to judge whether the study was successful or not, there was an improvement in overall survival associated with tisotumab vedotin in the hazard ratio here of 0.7. That was statistically significant. So I think, this hopefully will, the final approval is pending. This will hopefully lead to that final approval. It clearly met the primary endpoint. And there's a balance here with toxicity, and we're getting ready to talk about that next. But I'm excited about these data because this will bring, hopefully give others confidence to use tisotumab vedotin in the US, and then have this be available to our patients in the rest of the world. Some questions for me?
Great.
Yeah.
No, that was great. So I'm going to ask the same question to the audience. Now that you've heard the phase 2 and the phase 3 data, and if you haven't used TV, would you use TV in a patient with recurrent cervical cancer who has already been on PD-L1 therapy? Hands? Great.
Got some more.
Good.
Good.
Yeah.
Great.
So yeah, and I think we all agree, right? It is a standard of care, and there is an accelerated approval, and we saw the benefit of the accelerated approval yesterday, where a patient benefited and was able to come and tell her story. So I thought that was very impactful, and thank you for pointing that out, Leslie. The other question I had, Leslie, is, from the phase 2, the duration of response was, 8.5 or, months, and it was 5.6 months in the phase 3. Can you comment on that?
I can. I'm glad you asked. It's interesting. I don't think we'll be able to completely define that, but I think it's important that this was a checkpoint exposed, a somewhat checkpoint exposed population that probably makes a difference, or it may make a difference in terms of how patients responded to TV. TV does have, and as you pointed out, Dr. Campos, it does have an immunologic sort of effect. These ADCs have multiple mechanisms of action. So, could checkpoint affect the effectiveness? I don't know. I think in the grand scheme of things, it doesn't matter because it's still better than chemotherapy, and you can't take that away. And you really, we should be using our checkpoint inhibitors sort of earlier, where they probably work better. But I wonder if that may be what affected that. And then in any trial, if you start to expand the eligibility to a global population, to a larger scale population, it's not uncommon to see lower efficacy than what you saw in these smaller phase 2 trials.
Yeah, and I think also, you pointed out that the objective response rate was, lower, but still within the confidence interval. But I still think it was, more than 3 times that of chemotherapy, right?
Exactly.
And it's not also uncommon to see that objective response rate fall in a phase 3 trial, so.
Right, and we're gonna get into toxicity, and I think the toxicity of TV is a learning curve, so if you haven't managed it before, it can be a little bit intimidating. But if you look at the options, topotecan, pemetrexed, these are very difficult drugs for patients to take, especially if they've had prior radiation and they have bone marrow suppression. And so it can be difficult not only to give it, but to keep patients on it at a relatively good dose intensity for a longer period of time. So I think this at least gives them sort of the best chance.
Yeah.
Of that.
Thank you so much, Dr. Randall. Now I welcome Kathleen Lutz to discuss education adherence and symptom management in patients with cervical cancer treated with ADC therapy. And I'm very lucky to have Kathleen as my nurse practitioner who helps me take care of all these patients and always reminds me that she's seeing all my patients when I go away and speak to you all. So welcome, Kathleen.
Thank you so much, Dr. Pathori, for inviting me. And I'm super excited to, just kind of go over some symptom management and adherence and how do we make our patients successful. Well, I love hearing all the data. It's super great. The numbers are great. I've just learned so much in the last 2 days, and I will continue to learn. But now it's Tuesday morning, and I'm in the clinic, and I'm facing the patient face-to-face in the exam room. What am I going to say, and what am I going to do? And hopefully I could send you home with some good tidbits of information on how to manage these things, because we know that the only way to manage patients successfully is to be proactive. And that's kind of the spiel I give to all my patients on a regular basis, to be proactive, to be prepared. So just a couple of busy slides, but it's important to look at the most common treatment-related adverse events with tisotumab vedotin and understand that most of them were grade 1 to 2. So when I think of grade 1 to 2, I think I can manage them. I sort of explain to them that a lot of them are self-limiting, there's some mild things that we can do, but I feel confident that I can get you through them. So we have some anemia, nausea, the eye events, peripheral neuropathy, and some other ones that we'll talk about as we go along. So these are just some of the AEs in greater than 5% of patients in the tisotumab vedotin arm. So it's the ocular toxicity that we're going to pay attention to. We're going to focus on some peripheral neuropathy because we know that can be life-changing. We know that peripheral neuropathy, once it's there, may never go away. And what about the patient that plays the saxophone for her job? You know, she's in a band and plays saxophone. Or the patient that likes to sew for a living. So we really want to pay close attention to that. And then we have the epistaxis, which I honestly haven't seen too much, but I'd like to see, you know, maybe at the end if some of you guys can share some of the other events that you might have seen. So of course, the FDA approved this with this big black box warning. The eye toxicity, getting eye exams, adhering to the pre-medication, and things like that. Well, patients are going to see this and say, oh, I don't know if I could do this. You know, this just sounds like way too much for me. But I think it's important to point it out, but important to reassure them that we can do this together as a team. And a team approach is what the whole theme has been here this whole weekend, which I love, and I have the most amazing team back at NYU. And I couldn't do it without Dr. Bathory. So cheers to us. So patient adherence. What's the first step in getting patients to be compliant with all this is access to an eye care provider. We all work in different areas. Some work in cities, some work in rural areas, you know, some work in outside clinics, private clinics, and things like that. How do you find a good eye provider to be a part of your team? We're fortunate at NYU to have access to a lot of other providers to join our team. But it's also educating those the ophthalmologist on what we're looking for. We're lucky that there's good patient ed material and other material to share with these providers so they can understand what we're looking for. We know what we're looking for, but we're not the ophthalmologist. So we have to help them understand what it is we're looking for and how to do the exam. You know, do your patients have no insurance or emergency Medicaid or very poor insurance that doesn't allow them access? So those are things we have to think about in my role as to how I'm going to get these patients access to care. Access to the eye drops. Again, what kind of insurance do they have? Make sure they can fill the scripts, which pharmacy they're going to go to, and make sure they bring them to the clinic prior. And like I said, there's a lot of good patient ed material to be able to instruct your patients how to and when to do the eye drops. A lot of my patients are older. A lot of my patients are from poorer populations, low socioeconomic status. They might not have access to computers and phones and things like that. So I have to take all that into account. Then the last part of it is instructing your infusion staff. I put the orders in, I sign the orders, I see the patient, oh, you're cleared to go. Okay, bye. But now they need the infusion staff to build upon what I've already done, to educate them and work with them and reinforce the use of the eye drops, and then also the eye care, the ice packs before, during, and after infusion. There we go, it's that team approach. Without that team approach, we're not going to be successful. So the eye drop eye care plan. So just to go over it a little bit, the steroid eye drops, we know it provides protection against the erythema, edema, and pruritus, 10 minutes prior, 2 times a day, on the day of treatment, and then 3 times a day for 3 days. Well, what if I have a busy mom who has a little child at home and can't remember to do those eye drops? It's vitally important. The vasoconstrictor eye drops, which reduces blood flow to the eye right before the infusion, and then the continuous use of the lubricating eye drops all throughout treatment and for at least 30 days after the last treatment. Important tidbit is to make sure that they space out the steroid and the lubricating eye drops by at least 30 minutes. So it's a lot. We're asking them to do a lot of different things on a regular basis. I have to go to work, I forgot my eye drops. Or, you know, I didn't remember because the baby was crying or whatever. So there's things that we have to think about, that real life. Behind all these science and all these numbers are real patients that lead everyday lives. And then, of course, the ice packs during treatment and the eye drops, and for about 20 minutes after the infusion, if that's doable. Maybe they only have a limited amount of chair time on your infusion floor. We often run into that, so we get a little creative. So just symptom management with TV is obviously the eye toxicity I've talked about a lot. Peripheral neuropathy I want to talk about because it can be life-changing, like I mentioned earlier. What's their baseline peripheral neuropathy? What's their grade of peripheral neuropathy? Now I'm going to tell you, and I'm sure many of you guys have experienced this, the patients don't want to tell you because guess what? They want the treatment. They're not going to say, oh, I drop things, or I can't put on my jewelry, or I have a hard time writing with a pen. They're not going to tell you that, but you really have to delve into it. And I will say that the funny part is I'll go in to see a patient and they'll tell me one thing, and that yet Dr. Pithori will go in and they'll tell them another. And then we huddle together after, and it's like, wait a second, they didn't tell me that. And then we get together and realize this patient's having a real hard time with peripheral neuropathy. So we have to have a baseline before starting, and then that guides us in our decision-making as to dosing, dose reduction, holding, and things like that. Of course, we always like to use a trial of regional cooling of the hands and feet and a trial of some supportive meds like gabapentin or duloxetine. And bleeding, the last one I'm going to quickly breeze over, but monitor the source. Are they having the epistaxis? Is it annoying them? Are they in the middle of a business meeting at work and they're getting a nosebleed, That's the last thing we want to do for our patients. So monitor the source and the amount. I've had to send 1 or 2 patients to ENT just for quick evaluations and monitoring their labs. Other side effects which we know we can manage, the nausea, the anorexia, and fatigue. I feel like we're all expert at all of those things on a regular basis because pretty much every drug we use causes those things. This is just an example of what eye with conjunctivitis would look like. It affects the conjunctiva or the lining of the eye. And the keratitis can be pretty severe. I've had 1 case of it so far, and she did end up resolving and continues on treatment. But it can be real severe. I mean, it looks obvious that you'll see it, but I'm not sure I always will. This is just a real close-up picture. Red eyes, pain, irritation, blurred vision, inability to see. So all of those things, and obviously we want to get them right to, a good eye professional. I had a patient come in for treatment, blurred vision, couldn't figure it out, sent her back to the ophthalmologist, which I had her set up with one of mine, but she saw one of hers because she lives in the Bronx, and to come to Manhattan is very expensive. But I was fortunate enough to be able to reach out to the ophthalmologist that saw her, have a conversation with her, and she immediately said, have her come to my clinic right now. I'll see her, I'll evaluate her. I said, I'm giving you the TD handout so you'll know what to look for. She's continuing to keep in touch with me and is going to see her again before we treat her again, hopefully next week. It's that interdisciplinary approach. It's that team approach, and that's what's going to make you successful. It takes a little work on our part, but if you have great advanced practice providers in your office, they can certainly do all that. So let's just focus on another HER2-targeted ADC, trastuzumab deruxtecan. I was trying to practice that. Another ADC with great potential in GYN cancers. The main takeaway here, and I'm not going to, because I know I'm running out of time, is the increased risk of ILD pneumonitis. Talked about in the phase 2 Destiny Pan-tumor trial. Again, we looked at this earlier in terms of the grading of the AEs and the leading to discontinuation. What's the incidence of ILD pneumonitis? It's overall about 11.4%, with the majority of cases being grade 1 or 2, with 10%, there was a few grade 5 fatal toxicities. But most importantly, it's the workup. It's the silent workup. It's the radiographic findings that many of us might have overlooked. Most of the patients that I've seen don't have symptoms. They don't come in with that classic pneumonitis that we think of with immunotherapy, where there might be coughing and short of breath. They have these radiologic findings of an inflammation or infectious process. Immediately, you gotta hold the drug. You gotta get a non-con CT if you haven't one, and then again, enlisting the help of a pulmonologist to get some PFTs and bronchoscopy. Our patients don't have 4 weeks to wait to work this up, because most pulmonologists say, hold the drug, wait 4 weeks, and repeat the scan. Well, in 4 weeks, my patient's cancer is probably progressing. So it's staying on top of that and understanding that you have to kind of push them a little bit and educate them and find somebody good to join your team. And it could be challenging depending on where you are. So reach out to them, make contact, let them read some of the literature on the drugs, and that also will help. Our takeaways in terms of the pneumonitis, it's easy to miss. We had to go back and we reviewed a bunch of patients' scans and saw that it was present. It can rapidly progress. So if we keep on treating them, ignore it, and they have no symptoms, they're fine, it can rapidly progress. Does the risk of ILD pneumonitis increase with prior immunotherapy exposure? We know most of our patients with cervix cancer have had prior immunotherapy, and we're starting to see a little bit of correlation. Any suspicion on imaging requires workup, and obviously we want to hold it until it resolves to a grade 0. That's up for debate and discussion in a whole nother talk. But they're here to stay, okay? They're not going anywhere. They're challenging. I've definitely been working really closely with a lot of different ADCs on clinical trial, and they are a challenge, but they're exciting times. We're going to make a big difference for their lives. Close monitoring, proactive management is success for our patients. So thanks very much.
Thank you, Kathleen. You can sit down. Yeah. So, I mean, I think, a couple things that you said that were really important there is, have a provider that you can rely on, right? And in terms of both like a eye care professional, and they don't have to be an ophthalmologist, right? You can talk about that, Leslie.
Yeah, I mean, it's a surface toxicity, so really slit lamp exam and visual acuity are what patients need, and you'll have ophthalmologists turn your patients away. I mean, that's like a GYN oncologist being asked to do colposcopy, and they may not want to do those things, and so, but you do, I don't know that you can get any random optometrist. Like, it's like you said, you have to engage them and educate them.
Well, that's what, yeah.
Yeah.
Yeah, you have to find a professional that,
That wants to work
regularly.
with you and to help you, and then you can provide the material further, and that's what I did with that one example I gave you, and she's been terrific about reaching out to me. And it's more convenient for the patient to go local, too.
And if you want to know what I really think, you have to ask my nurse practitioner about it.
All right. So I just want to ask the panel, like, what has your experience been in terms of using TV?
Actually, I have to say, we've used it extensively, and I have not been at all, like, it's not been a big deal to actually use. I think it takes a little bit of organization, as you mentioned, getting the eye facility, but it's not been huge. There's education that has to go into it because it is quite labor intensive to understand the different eye drops, how to apply them, and the like. But the actual administration of it has been actually seamless, to be honest with you, at this point in time. And it's not the ocular toxicity that I know it's black box. It's the peripheral neuropathy that you have to pay attention to, because these patients have been previously exposed to a platinum, a taxane.
Yes.
So it's the peripheral neuropathy that becomes more of a nudge than the ocular toxicity. Yeah.
Yeah, and I've also noticed that, the peripheral neuropathy isn't also, can be more of a motor,
Yes.
Neuropathy, which to me is a little bit more troubling. So you really do need to be on top of that.
My first one, the patient said, "Oh, I fall down. I got up to go
Yeah.
to the bathroom and I fall down." And I'm like, "Well, what is that? That's like fatigue, that's like weakness, like what is that?" And it turned out to be more of this motor neuropathy. And I think we were running 204 and 205 and starting to notice, we weren't getting that classic taxol neuropathy at all. And it can be we call it peripheral neuropathy, but if you look at the label, there's this sensory motor. And when I read the label, I thought, well, that's just all over the place. But the reality is that's what's actually happening to our patients.
No, it definitely is, Yeah, we've definitely seen it with patients with some muscle weakness. I have leg pain, I'm having trouble walking. I've had to hold it for those reasons, and then sometimes dose reduce. So it is multifaceted. There's a lot of things that can go on. But really, when you're at the bedside, we only have 15 minutes most times, but you really got to get as much information as you can.
Yeah, and I couldn't agree more about, who is afraid of the ocular toxicity? I was afraid of it, and I
Raise
had
your
seen
hand.
the patients on the trials, and
Maybe we could see a show of hands.
yeah, who is afraid of the ocular toxicity? Don't be embarrassed, because you just care about your patients, right? And I was afraid of it too, and even though I had seen it in the early trials, we know that these things get bigger as we expand them to, the patients who aren't the perfect candidate for a phase 2 trial. And that's a serious toxicity, but the whole thing with the grade 1, the grade 2, the surface, that nobody went blind. I mean, the first time I tried to give this infusion in my infusion center, the nurse had Googled it and said, "Oh, that patient's going to go blind. I refuse to administer this infusion." And I had to go to the infusion center and just kind of, just coach them, through that. But yeah, it hasn't been the big issue, really. The neuropathy has been the...
Yeah, and I do want to echo that, the most common ocular toxicity is conjunctivitis, which is pink eye, right? It's just inflammation, so, which is quite manageable, right? The one thing I do want to go back to, I know that, we've all used the drug and we're comfortable with, the eye care plans and getting these patients to an eye care professional for exams, and, you're supposed to do it prior to every cycle, right? What about the social determinants of health and, we know, right, that cervical cancer afflicts, patients of minorities, in greater proportion who have more issues in terms of even coming in for these exams. How do you manage that?
Well, I think from my standpoint, with the patient example that I used, is really to try to find somebody local, and which is what she did, because she lives in the Bronx, and coming from the Bronx to Manhattan, if anybody knows New York, can be very expensive. And most of my patients take public transportation. Really, who wants to go on the subway nowadays? Not me. But, it's working with the providers. It's reaching out to them and, giving them the information on what we know and how to do the exams and forming a relationship with them. I think that's the biggest thing. But you're absolutely right. Getting the care that they need in certain situations is very challenging, and we work hard with that every day.
Yeah, I mean, we're a so-called safety net hospital, and so these patients are a priority, and we have teams assembled to help these patients with the social work, and even then, it's really challenging.
Yeah.
And, compliance can be challenging because these patients have a lot of challenging other issues in their lives. Like you said, they're real people with real lives, and that can be difficult. But I think you just have to, do the best that you can and do the right thing for your patients.
Yeah, I think the team approach, right, and really having your teams involved in counseling and helping them get through the therapy, because I think all of us have been able to get these patients through these treatments.
And reach out to the company. I mean, I've had, the patient that I actually shared with you, I'm not kidding you, she's, you think, she's coming from China, they're paying cash for, treatment at Dana-Farber. It's ridiculously expensive, and it is. The first cycle might have cost her $80,000, and this patient was about to go back home to China, I'll tell you very honestly, because she didn't want to incur costs to her parents, because she never thought she'd be able to pay them back. And that's exactly what she was thinking. And we reached out to the company, and we were able to get that entire treatment, cycle for $3,000, something that she could, which is still a lot of money, I know, but it's something that they could do. It was a difference between giving her her second cycle or not.
Yeah. So Leslie, I adore you. However, I know you agree with me on this, but I am disappointed that we didn't show race ethnicity data in the 301 trial.
Well, my hope is that we still can.
Okay, thank you.
But I will say, it was a challenge. Because of the accelerated approval, we ramped it up in the U.S. really fast, and then we closed it really fast because the drug was available and patients didn't want to be randomized to the non-tisotumab arm, understandably. And so I think, diversity is, as you know, and
that's
I
why
adore
I said that.
you too, it's a very complex issue, and I think that, we need diverse populations. It's a global trial. You need diverse populations in each location. We can't rely on, Asians in Asia to represent Asians that live in the United States because there are different social determinants of health, as you pointed out. But my hope is that we can still report that data. It was prioritized, but we were moving quickly.
Great.
And when you move fast, those patients get left behind.
Thank you. So I want to hear from Andrea. But before I have you invite you up to speak, I'd love to hear, just since we were talking about the, adverse events and the eye toxicity, does that, if your doctor, I know Dr. Solani is your doctor, and I actually want to give her a huge shout out for connecting us, and we're so fortunate that, you're here with us. If she told you about these eye toxicities, would that be a hindrance to you? I'd like to hear just your perspective.
No, I don't think it would be a total hindrance. I would probably ask a lot of questions and then learn about what I need to do. And I would weigh the benefit, which, basically is, do the treatment with TV and deal with the eye with the eye stuff that you have to do, or potentially continue on with cancer that can go very bad. So to me, it boils down to that, it's worth it.
It's worth it if it's going to help you,
Yeah.
if it's going to work.
Yeah. And it is always good to hear, like, oh, it's only been 1 and 2, and then if this happens, and Dr. Solani is always great, well, if that happens, then we're going to do this. If you get an eye, I haven't done that treatment, but she would probably say, like, if you get an eye issue, we'll treat it with these medications, et cetera, and I would just be ready for that.
Great. And what about the neuropathy that we talked about?
Yeah, that's interesting. I'm a very active person, and so
Yeah.
that would be, that would give me a little pause, just because it would be a bummer if I couldn't, do the things that I do. But again, at the end of the day, hopefully, you did mention that it could be permanent, which is a real bummer, and that does kind of suck. But again, if the alternative is that you might have a much shorter life, then I guess I would find other hobbies.
Well, that's kind of sad, but
Well, but it's true,
but
right?
it also goes to show you, right, how much you are willing to give up, right,
Well, yeah.
to get control of the cancer. So, yeah.
Right, because what I don't understand is how anyone would look at it. It's hard for me to understand that, like, well, would you opt then for actually just a much shorter life? Because really, isn't that the alternative?
Yeah. Yeah, thank you. Go ahead, Leslie.
Can I respond?
Yeah, please.
I love that you said that, because we had a panel like this, gosh, it was the IGCS in New York, and I'll never forget it, because a patient said, what you're saying is almost exactly what she said, and you probably have never met her, but she said, I don't think that you all understand. She said, if you gave me a plate full, and this is a little gross, sorry, it's lunch, but she said, if you gave me a plate with dog feces on it, and you told me that I could live longer if I ate that, I would probably eat it. And she's like, I think she was just using hyperbole to prove a point that, you all get these toxicities that you all are debating and feeling nervous about and concerned about. Like, tell me you're going to monitor me for them. I'll feel like I have a big safety net around me if you say that word monitored, but don't decide that I shouldn't get the treatment because I could potentially get those side effects, because you would be surprised that my perspective on them may be different than yours. And that just has always stuck with me, and that's been a couple years, I think.
Yeah. Great. That was an excellent point. Thank you for sharing that. Andrea, why don't you come on up and share your perspective with us?
Okay. Good afternoon, everyone. I'm Andrea Kinlock, and I'm here to share my patient journey. My story exemplifies how life can depend on what doctors you choose, that medicine is an art and a science, and how I found a whole new philosophy on how to live my life that came from a most unexpected place. But I'll get to that in a minute. First, I want to say thank you to Dr. Pathuri and all the doctors on this panel for your incredible work in what you do and for including me. And I also want to say thank you to all of you out there that also do this work and are doing it successfully. I literally wouldn't be here without you, and I am truly grateful. My journey began in 1998 when I was 33 years old. My pap smear came back irregular. My doctor at that point didn't know why, and she had me come back 3 months later for another test. Eventually, she discovered that I had HPV-16 and it was associated with cervical cancer. She called me at work to tell me and said right there on the phone that I should have a hysterectomy. I burst into tears. I hadn't yet had children, something I always wanted. So instead, she performed a cone biopsy and got clear margins and said it was only pre-cancer, not actual cancer. She referred me to a gyn-onc, and I went to that person for every 3 months for colposcopies. I was clear for a few years, and so I was referred to a new OBGYN with the goal of getting pregnant and having that baby. And that I did. In 2004, my healthy baby boy was born. Oh my God, look at how cute he is. And he's such a great kid, and now he's a young adult. And I'll just leave these up here for a little while for you to enjoy. For many years, I continued with the same OBGYN. We'll call him Dr. Baby. He was fully informed about my HPV and precancer history. Years passed with regular checkups. Occasionally, if I had an odd pain, he'd do an ultrasound in the office. We had a really good rapport. He had a son about the same age as mine, and we would talk about kids and school and parent stuff. In 2019, the company that I was working for changed insurance benefits, and they only offered HMO insurance, which meant I had to change doctors. I went for my first checkup with the HMO and had an abnormal pap smear. So they sent me for a colposcopy, abnormal. Then a biopsy, and you probably guessed it, I had cervical cancer. The new gynonc, we'll call him Dr. HMO, asked me if I'd had recent abnormal pap smears. I told him no, I hadn't. But to be sure, I pulled up my electronic records from Dr. Baby and was pretty shocked to see that my last pap had been abnormal. I called Dr. Baby to tell him I had cancer. He was stunned. I asked him why hadn't he done the colposcopy when I'd had an abnormal pap result. But he said that at that point in time, it wasn't the standard protocol, and that his patients don't want that kind of test. I noted, though, that he knew I had the history of HPV-16, and it would have been warranted. I was your patient, I said. I would have wanted that test. He didn't know what to say. He knew I was right, and he did feel terrible. He called me regularly to check in on me. I know he cared a lot. He just had failed to be thorough. Meanwhile, I got ready for surgery. I hired a nutritionist to get into optimal health. I stopped eating sugar, I stopped drinking wine with dinner. I wanted to do all that I could to get myself through it and recover quickly. In September 2019, I had that hysterectomy. Afterward, Dr. HMO recommended chemotherapy and radiation. I cried. I don't know why I didn't assume that that would be the case, but I didn't. However, the radiation doctor said I only needed radiation, not chemo. I told both of them to please thoroughly discuss it and give me the best recommendation. They decided no chemo was necessary. I'll admit, I was kind of happy and relieved that I didn't have to go through that. I went along living my life 100% confident that cancer had been excised and that the radiation had provided insurance against any future threat. I did the standard checkups, I played tennis, I hiked, I raised my son, I went to work, and I'd all but forgotten about cancer. 2 years went by, and then in the fall of 2021, my right breast became sore, achy, swollen, and red. I called my primary doc and told her about it, and she sent me straight to urgent care. That was a little alarming. After several visits, a mammogram, an ultrasound, and finally a biopsy, the result was a return of the dreaded cervical cancer. As quickly as possible, I got a PET scan and an urgent appointment with my gynonc, Dr. HMO. I was shaken, nervous, and scared. My wife was with me to help me process whatever information I received. When Dr. HMO came in, I think I asked him, "What do you think?" Or maybe I said, "How does it look?" Because I will never, ever forget his response. He looked me straight in the eye and said, "It's horrible." My wife said, "Honey, I think he's kidding." Because it did seem kind of crazy that a doctor would say this to you in this moment, that essentially death is imminent. Because what else does horrible mean? "I don't think he's kidding," I said, and he confirmed it. "No, I'm not kidding." That word reverberated with a dark, deafening echo. I thought, I'm too young to die. I have a teenager. What about graduation? How will I help him pick college? What about his wedding? What millions of moments will I miss? And how would losing me affect him and my wife? I asked him what this meant. Will I live for a couple more months? Well, yes, a couple months. Oh, a year or maybe 2 years? I asked, negotiating with him like it was a business meeting. He looked at his nurse as if weighing the answer, because maybe not, it seemed. It depends on how well treatment works, he said. Okay, well, at least horrible didn't mean I was dying in a month, which is what I had thought it meant. That was the worst moment of my adult life, and I can never unhear that. I started chemo immediately. These 4 drugs, which I cannot pronounce. I'm glad I'm not the only one. It was December of 2021. Meanwhile, 2 weeks before all this happened, I had been offered and accepted a new job. It was a big job with good benefits. I didn't start until January 1st, but the only thing that I negotiated was that my health insurance begin right away, rather than after the standard waiting period. After that horrible experience, I wanted to find a new doctor ASAP within a system that gave me more options. I spent the month of December going to chemo and searching for a new doctor. I was looking for a top specialist for cervical cancer, someone who was involved in research and clinical trials, and someone who would treat me like a full person with care and compassion and who had high emotional intelligence. I interviewed docs at Cedars and City of Hope, and then I found Dr. Solani at UCLA. Sorry. She checked all the boxes, but she also felt right. She sat with me and my wife, and she talked through things. She pointed out the positives I had going for me. She was pragmatic and balanced, explaining that there were more options after the current treatment if, for some reason, it didn't work. She drew a graph of the range of possible outcomes. She put the infinity sign at the end. That made me smile and made me feel hopeful that I would live beyond a few months or even a few years. Maybe I'd live many years. She wasn't careless with her words. She not only had compassion and emotional intelligence, but she also was knowledgeable and involved in cutting-edge treatments. She was definitely the right doctor for me. I lost my hair by the end of December, bought a good wig, started my new job on January 3rd, and switched my care to UCLA. I'd work from home on Thursdays, which meant I'd go to chemo that day, laptop in hand, recover over the weekend, take Zofran around the clock, and I'd go to work on Monday. Every 3 weeks, rinse and repeat. Once I knew what to expect each time, it became easier. No one at my work ever suspected. The chemo worked great on me. PET scans showed really good results, though Dr. Solani noted that we would need to take a closer look at that spot on my lung that had been showing up since 2019. Did Dr. HMO ever biopsy that? She'd asked me in the initial appointment. No, he hadn't. He said it was probably scar tissue from some past bronchitis. After the next PET scan, when the lung spot was not bigger but looked different, Dr. Solani sent me for a biopsy. It was positive for cancer, but not cervical cancer. It was lung cancer, a whole different one. If only cancer were the same as winning the lottery, I'd be rich. That was a pretty big shock for someone who has never smoked, and it was sitting there ever since 2019. But Dr. Solani referred me to other great doctors, and before that surgery, again, I stopped eating sugar, I stopped drinking, and I made sure to get my cardio, my lung capacity as strong as possible. I tore out my front lawn, I re-landscaped it by hand, I went for more hikes, I played tennis, and I went for long walks with my wife every night. In November of 2022, they cut out half my lung, and thankfully, all of the doctors involved concurred that no further treatment was needed for that one. I learned what to expect. 3 weeks of recovery, then breathing and lung rehab, and then I'd be back to playing tennis. I focused on that, and that's what happened. I continue with my immunotherapy and see Dr. Solani every 3 weeks for monitoring. Ever since that horrible day, I never again asked, how do things look, or what's my prognosis? And here's where that new philosophy on life comes in that I might have mentioned earlier. One day, I was driving and I saw a billboard, and I don't even know what it was advertising, but the slogan said, "What's the best that can happen?" It turned that old axiom inside out. I had a moment of epiphany, and I felt myself light up inside. The next time I saw Dr. Solani and there was another bump in the road, a few little cancer cells were hiding out in a lymph node, I asked her, "What's the best that can happen?" She lit up too, and she laid out the various options. We went with doing focused radiation in a specific area, then continuing with immunotherapy through the standard course. She added that the best that can happen is that we eradicate every last cancer cell in my body. It's my new favorite word, eradicate. Sometimes I meditate and I even imagine my good cells beating up and eradicating those cancer cells and showing them the exit. And before you think I'm naive or maybe just nutty, I know I cannot control the cells in my body, not fully anyway. But if there is any mind-body connection, it certainly doesn't hurt to meditate on eradicating this cancer. It helps me feel positive. It reduces my stress and focuses me on positive outcomes rather than negative ones. It's been over 4 years since my initial diagnosis and just over 2 years from that horrible day of recurrence. And I'm still here telling you my story. My last PET scan looked really good, and I am well aware that I would be dead by now had it not been for certain choices that were made along the way. And there's one last thing I want to say. While it's hugely important to have doctors who are knowledgeable, attentive, thorough, emotionally intelligent, and compassionate, it's also important for the patient, me, to be a self-advocate and a good partner. I know eating a better diet won't cure my cancer, but it might help me heal faster from surgery or chemo. Same goes for exercise and managing my mental health. Also, standing up for myself and asking about all the options. None of it hurts. We know that. Those are my jobs, sometimes with the help of other care providers. And it's up to me to ask about, report, and manage the side effects. They will happen, and they will end. I will feel better. Most side effects won't last forever. I accept this, at least some of them will be there, and I'm ready to do what's needed to manage them as best I can. And that in the end, it's worth it. And it is, because the alternative is worse. So maybe that's a takeaway for today. Let's be good partners to each other. Partners collaborate, they talk, they trust each other and can question each other. They respect each other. They carry their weight. If you don't know how much information a patient wants, maybe just ask them. Perhaps some patients do want to know all the statistics and tragic possibilities. Others may want to stay on the hopeful side. No matter which, try to be a good partner and ask your patients for the same. And if you're not sure whether or not to do this, let me ask you, what's the best that can happen?
Andrea, that was incredible. Thank you, thank you, thank you. You made some very, very important points. You know, I learn every time that I have patients speak to us, and I think we're also grateful to hear your perspective. Clearly, you know, how you deliver news is really important, right? Our communication is really, really important. So thank you for sharing that tidbit. In addition, you've had an incredible journey. You are so resilient, so strong, and really, we are grateful to have heard your story, and I think all of us will be better doctors, better caretakers with your perspective. So really, thank you, and thank you, Dr. Solani. She's right there.
We're very much in awe of your penmanship on that piece of paper,
Yeah.
okay?
Thank you for sharing that too.
That's
Yeah,
the
we were.
Catholic School 101, Palmer. Very good.
Anybody have questions for Andrea?
I really enjoyed hearing, and this is something I think is quite important, because sometimes as a physician, you just never know how to approach the patient. You want to be truthful, you want to be honest, you just want it to come across right. And you sit there in the room, outside that room, thinking, how am I going to say this in a way that doesn't devastate someone? And you said something. Ask them how they want to hear the information. That's actually very important. Yeah.
Yeah, and I think that that's probably, thanks. I think that that's probably still hard, because how do you even say that? Because then you're asking the patient, do you want to hear the worst? Or do you want to hear the best? Like, you know, but I think if you can go in and phrase it like, and get a feel for them and how they are, and that probably just takes a minute or two to find out, you know, do you have anyone here with, you know, that can help you through this, or, you know, how do you want to hear this information? What would you like to know from me? Maybe that's what it is, right? And then, you know, and either way, like, I kind of feel like that was such a weird experience, because I don't think that anyone else would have ever said that horrible. I don't think that anyone really would. It was just an odd, I don't know. But I think that you can get a feel for it and then ask them, you know, what do you want to know from me?
Right. And it stems from your relationship that you've had also.
Yeah.
Yeah, and I think you also made a really good point about partnership and advocacy, right? So, and really finding that physician that you trust, right?
Yeah.
And that you're able to go back and forth and have honest conversations with.
Yeah. And I thought a lot, by the way, when you were speaking, because you talk about the patients and how, yeah, it's a lot to ask from them. They have like a lot going on in their lives, and everyone does in some way. But I think also asking the patient to be a partner too and part of the team, and it's like empowering to them, but it's also putting an expectation on them that like, you have to participate in this and you are part of the solution too. There's something about that, like in any role, right? In your job, like even when you work with people in your job, when you say those kinds of things, they feel more involved, more, there's more at stake. They obviously have a ton at stake, but they feel more ready to participate and make those things happen. One thing that patients, well, for me anyway, people always ask you when you tell them you have cancer, oh, what can I do to help? And that might be something good to remind your patients. I bet you had friends and family who asked, what's that can you do to help? See if they can drive you to the ophthalmologist maybe, or, and I've done that. I had a, friend who, my wife had a busy work day, and I asked someone else to take me to one of my appointments where I couldn't drive home from it, I forget which one. And he did, and it wasn't even like a super duper close friend, but people want to help. And then that also,
Yeah, great. Thank you again. I'd love to open it up to questions in the audience. Does anybody have any burning questions?
While people are coming up to the mic, I'll just say, since, and come up to the mic, ask questions. It's gotten, since COVID, it's gotten really hard to deliver care in the cancer arena. I think all of us have had staffing turnover issues and, just time pressures and things. And, thank you for reminding us, because it can be easy to forget. I know I do. Forget just how impactful those words can be. And they may not seem impactful to me, but they can reverberate and become this mantra. So I don't know, maybe I'm thinking here I should take a time out before I walk in the door. Just check yourself.
That's
All right.
important.
Yeah.
Yeah, that's definitely a good point to make. I know that, before we go in the room, we definitely have a conversation with, how are we going to approach this? We, unfortunately, or fortunately, I don't know which is worse, Dr. Pithori had been away the last 2 weeks, and I did have to deliver bad news, to a few patients and explain to them that their cancer has progressed. And it's looking at the full gamut, obviously asking them, we have to talk about your scan. Do you know what the results are? Do you want to call anybody? Is anybody here with you? And then I go over the scan with them in detail and lay out the plan and look at the positives. The positives of you're well enough for treatment. You're not having any symptoms. And it's hard, it's not easy. We do it every single day. All of us do it, all of you guys do it. I don't think it ever gets easier. Practice, I don't think practice in that part makes perfect, but just kind of taking a step back, taking a breath before you go in the room and, kind of preparing in your mind might help too. But thank you for all your good insight, Andrea. It's been so helpful.
Yeah.
I think what you said, I think you have to deliver this news and you have to do so honestly and compassionately, but you must deliver a plan. I think if people can leave a room knowing that there's a plan, they carry something home with them.
100%, yes.
Yeah, agree. Well, if there are no questions in the audience, I'm going to ask a question. So I know you put up all the different, options for the treatment of recurrent cervical cancer. So, how do you decide between TV and, say, trastuzumab deruxtecan, right? So they're both available now. And what percentage of patients do you think really is a candidate for trastuzumab deruxtecan?
I usually go to tisotumab because this is where the data is. It's FDA approved in cervical cancer, okay? Am I excited about the Destiny pan tumor? Absolutely. But I showed you and I specifically highlighted a certain point. I said there were 8 patients in the IHC 3+. And if you have to go back and add the numbers, because technically that cohort was 40 patients. So where are the other 12, okay? So I went back to the original manuscript, which is in JCO, and it really came down to, in all honesty, in terms of the testing of the HER2/neu, okay? I think they tested it like the gastric type of testing. But things that were originally read as IHC 2+ didn't pan out. They were 0, they were 1+, which didn't make the eligibility criteria. So it's not that easy to find IHC 3+ or 2+. I think we should look, because at the end of the day, we're looking, it's not about one or the other, it's about having as many treatments as you can possibly deliver to the individual. So please look, but at this point in time, my go-to is tisotumab because it's FDA approved, but I basically throw out that net for anything, to be honest with you.
What about you, Leslie?
Yeah, I take the same approach. I think even though the numbers are small, you can't ignore, there are very consistently high response rates to trastuzumab deruxtecan. So, clearly that's exciting. The ILD is a little concerning. So
Yes.
when you do want to use every option, you don't want to get something in the second line that prevents you from using something in the third. And
Absolutely,
so
yeah.
I think maybe if you get that ILD with early on, then you may limit yourself down the road with it. So,
and it's so interesting. We spend so much time talking about ocular toxicity, not us, but the world. You know what I mean? I am not afraid of ocular toxicity. I'm not good with eyes, but I'm not good at ocular toxicity. But I am deadly afraid of interstitial lung disease and pneumonitis. It can turn on you in 2 seconds. Yeah.
No, definitely.
Yeah, and I think that also the HER2 ADCs are only going to serve a very limited population, right?
Yes.
We probably don't even know, what the true incidence is of 2+, 3+, right? So
Yeah, and it
we
looks
know
like
the
it's
more
mostly
classic,
adeno.
right, 2+, ish positive or 3+, and that's very small percent, right? Like 5 to 15%.
It may, it may actually have more applicability if this was an endometrial cancer discussion. We could go on and on and on. But I think in the cervical world, keep in mind, it's not the first time they've looked at this. They've looked at mutations. We're talking about IHC, overexpression. But they've looked, in the Summit trial, looked at HER2/neu mutations with neratinib.
Right.
And again, it exists. And, you throw it out there. If you can find something more for your patient, by all means. But it's few and far between.
Dr. Bookman's always bringing up this argument, if we ever get our act together with the HPV vaccine, then we would eliminate squamous and adenosquamous, and we're going to be left with these rare glassy cell mesonephric tumors. And, I don't know what their HER2 expression is, but right now most of the HER2 is in the adenos and maybe the adenosquamous histologies, and maybe some of these more rare histologies are more likely to have HER2 expression. I don't think we even know. They're so rare, we're not even looking or reporting.
It makes me think of I might start looking.
But I actually test all my
too.
cervix
Exactly,
cancers
yeah.
because I want to,
Yeah.
exactly what both of you guys said, I want to use all the agents that I have, right?
And I have to say I have 2 gastric types, which, torment me because there's so limited data. They were both IHC 3+. I'm serious, yeah, I'm serious, yeah. So think, you should think, we all should think, I should say, yeah, exactly, yeah.
All right, well, I think,
Oh, somebody the mic.
oh, great, yeah, thank you.
Nana Pinelli from Jupiter, Florida. I'm so glad you guys brought up vaccination. I give talks at the local high school as much as I can
awesome.
about vaccination. And sometimes I'll get the parents, the anti-vaxxer parents coming to help me. Other times, it's actually been really good because the kids really seem to get it. We have a medical program in our high school. A little embarrassing when my kids were in high school there, and the teachers all made them leave whatever class they were in so they could make sure they saw my lecture. But anyway, vaccination. What do you think? I'm trying to tell every single one of my patients and every single grandmother, make sure your kids, your grandkids, because I get grandmothers coming in with cervical cancer, right?
Yes.
And what do you think about someone like you? Thank you so much for your story. What if we had vaccinated her when she had that first episode of HPV? Because I'd seen, I guess, a couple of studies about maybe giving somebody the HPV vaccine. I know it may not eliminate the HPV-16, but what do you think about vaccinating our younger patients who haven't been vaccinated yet, who already have HPV-related diseases?
Oh, yeah, 100%.
Yeah, I recommend it, and I tell my patients to get it.
Yeah.
Absolutely.
I think we do, and there was kind of this narrative that, the data doesn't really work if you've already been exposed, but I mean, how many of us anecdotally have seen people with just like the most stubborn, persistent HPV completely go away with vaccination, even a therapeutic, even though it's not supposed to be therapeutic. Right. And that's an off-label, and we're not here, to talk about the vaccine per se, but I think that it's not unreasonable, but the effort needs to be to give it to who it's, intended to be for, right? The effort is not to catch up. The effort is really to try to get it in. And I hear you, the anti-vaxxers. I mean, kudos to you for standing up. I don't know that most of us don't have the intestinal fortitude to do that.
Yeah.
And, really appreciate that you, doing that. Thank you.
Yeah, but I agree. Let's get back. You can vaccinate as early as age 9. So, and there's talks of even trying to move that up earlier. So,
Boys, girls.
yeah, all boys and girls should get vaccinated, right? I think we have another person up at the mic.
I'm Zoom up from Phoenix, Arizona. So I'm just curious, when you are doing your testing on these tumors, are you doing it like right after initial diagnosis to kind of inform possible future therapy? And are you using local testing? Are you sending it to a central lab? And do you think that maybe we should talk to our pathologists and make this more of an automatic thing like we're doing for profiling for our uterine cancer patients?
Yeah, thanks, Lindsay. Great comments.
I mean, honestly, we don't get HER2/neu on, and I understand there's a cost. So, we still have to ask for PD-L1. So, but do I hope? Like, I did breast cancer for many, many years. I want an ER/PR and I want a HER2/neu or an PD. I want the entire thing, just at my disposal. I realize there's a cost. You know what I mean? And I have to be cognizant of that. But we don't have that at that point in our institution yet.
Yeah, I've actually talked to our pathologists now that we have an NCCN listing that every cervical cancer patient that we have, that we get this testing on, especially advanced. Yeah.
Another thing, we're not here to promote any testing companies, but I test at the frontline metastatic stage. I think that's the first time that it's very relevant. So you're getting that CPS score to inform your Pembro with or without. And we'll just go ahead and send it for NGS at that point. And right now, we're using Caris because they're doing the HER2 IHC. And you don't have to say, I don't know if they're doing breast or gastric. Like we kind of started out using breast criteria for GYN cancer.
Yeah, we use breast, and we do an in-house test.
Yeah. But really, Destiny Pan used the gastric scoring, and it's a little bit different, and so probably we need to be using the gastric scoring in that sense. So I probably should go home or should I log on right now and figure out which one they're doing, since I don't know.
All right, I think in the interest of time, we're going to wrap up. But before we wrap up, I want each of you guys to tell me what you are most excited about for the future in the treatment of cervical cancer.
I hope we don't have to have a discussion about metastatic cervical cancer. I want to be able to treat people early on and then let them go on, forever. I think, one of the earlier cases that I had with cervical cancer 20 some odd years ago, and granted things have changed dramatically. What we haven't discussed here, because there's just no time, is the pain management of patients with cervical cancer and locally recurrent cervical cancer, which is horrifying. And, I have seen patients in that situation where we've had to employ ketamine and so forth, things we never thought we had many years ago. And not to have a patient have to live like that or die like that would be wonderful, to be honest with you.
Yeah, I'm excited that we're really ramping up our diversity efforts because, too many people who need these new treatments aren't getting them, and it's just hard to talk about them and get excited about them knowing in the back of your mind that the people that need them may not have access to them. So for me, just that's what's most exciting. So we're finally talking about it in a more meaningful way.
Kathleen?
I think I'm most excited about the various options that we're going to have moving forward and the ability to manage them as successfully as we can so that our women can continue to lead their lives as successfully as they need to.
Andrea?
Well, I guess I'm excited about the idea of eradicating. When I started on the journey, it was more like, well, this will be something we kind of probably have to manage. And now maybe it's something that can be eradicated, I hope.
Yeah, thank you. We all would love to eradicate cervical cancer. I like that word too.
Yes,
So
cheers to that.
thanks to Dr. Solani. So I just this will conclude our symposium. I want to thank you, Susanna, Leslie, Kathleen, and Andrea. You guys were awesome. And to all of you, thank you for joining us
awesome too,
and being active in your questions. And this session will be available on demand. You can go to www.gog.org for more details. If you wish to access and watch this program again, the GOG Foundation would like to again thank Seagen and Genmab for their generous support so we could have this incredible session today. Thank you all.